Thank you, Tony. I'm glad you're all here. I'm glad to be here too. I get to talk about my favorite topic, psoriasis. So I'm glad I was given 45 minutes. But when I think about how much there is to learn and how much there is that's been published and how much sort of things that have been coming out in the last 10 years on psoriasis, both from the science perspective and from the therapeutic perspective, I could talk for hours. So it is really a challenge to do it in 45 minutes. I think some of you who are well known to this topic area may find this maybe a little too basic. And then on the other hand, some of you in practice may find it a little too detailed. So I'm trying to strike a balance and try to make everybody happy. I'm going to try to give pearls for practitioners and then some higher level things about what's to come in psoriasis. So it'll be a mixture. Hopefully you'll learn something. So I used to be an academician. I spent 19 years in academics. And then the last 11 years, as Tony mentioned, I've been running a trial center. So I spend 100% of my time doing clinical trials in dermatology. So I see patients every day, but they're all in trials. So I do no private practice now. Because of that, this is my conflicts. Basically, I work with pharma to come up with new drugs for our specialty. I also do a lot of consulting as well, but I'm well known for speaking my mind and having my own opinions. So this talk is completely my own, and it's not driven by any drug company. So how many points is this? It's 11 points. It's kind of unrealistic, though, because there's 9 tiles used, right, instead of 7. So there really is a lot to discuss about psoriasis. There's comorbidities, there's basic science, therapeutics, and so forth. Again, I'm going to try to take you through what I think are the highlights for what you need to know today. So for me, I spent 20 years running an immunology lab. I worked in the basic science of psoriasis. To me, this is a pathway that everyone should know. It's called the IL-23 Th17 pathway. You'll see different versions of this in different publications. Sometimes it's more complex than this. Sometimes it's less complex than this. The basics that you need to know, if you don't know already, is that IL-23 is a master cytokine regulator of psoriasis. IL-23 is the key, sort of the Wizard of Oz behind the curtain, controlling everything. I call it the head of the snake as well. If you want to hit psoriasis and with a single blockade of one cytokine, it would be IL-23. So you really need to remember that. So what does IL-23 do? It stimulates T cells, in particular Th17 cells, seen in the middle here, and TC17. So if there's CD4 positive T cells, it's Th17. If there's CD8 positive T cells, it's TC17 cells. The normal pathway that we're seeing here is active in our mucocutaneous tissues in our body. So within our oral mucosa, within our skin, when we have pathogens such as Staph aureus and Candida albicans in particular, so gram-positive bacteria and Candida, we get activation of this pathway. Okay, so it's a normal immunologic pathway that helps us fight off things in our skin surface. In psoriasis, however, it is elevated. Everything is higher, and there's no staph in psoriatic lesions, and there's no Candida in psoriatic lesions for the most part. So the lesions are not infected, but we have upregulation of this normal immunologic mucocutaneous defense pathway. It's really important to remember what it does normally, because when we target it, What we don't get is systemic infections or things we would see with TNF blockers. And the reason is because this is a mucocutaneous defense pathway. So we're not impairing systemic immunity when we're blocking IL-23 or IL-17, for example. The other important point of this slide is that there's at least 3,000 genes and subsequent proteins upregulated in psoriatic lesions. It's a lot. So the early gene expression studies by Jim Kruger and others, if you do a biopsy of lesion and a biopsy of non-lesion, compare the gene expression, you get thousands of genes upregulated. An important point is that does not mean that there are 3,000 targets in psoriasis. Almost all of those, the majority of them, are secondarily upregulated and driven by IL-23. So just because something's elevated in tissue, we heard that with IL-17, a couple talks today. Oh, IL-17's upregulated in the tissue of HS, let's say, or some other diseases. That doesn't necessarily mean an IL-17 blocker will work. So you have to have upregulation, you have to have biology going on, and the cytokines have to be central to the pathogenesis. And what I'm highlighting here in yellow, IL-23 and the IL-17 family of cytokines are central. They're key cytokines upregulated in psoriasis that are driving the inflammation. Okay, so I'm going to switch now. With that background, I'm going to talk about the drugs now and tell you why and how they fit into that background. So let's talk about topicals a little bit first. For many years, we didn't have anything going on in the topical realm. And all of the advances were in the biologic realm, right? And so interesting that we have two new drugs now that are making their way. The one that was just approved as of last week called tapinarof, and then another one that's likely to be approved soon called roflumilast. So I'm going to tell you about those two and why they might be interesting for us. So let's start with tapinarof here first. So it's a completely different mechanism of action than corticosteroids. It's completely independent of vitamin D and vitamin A. There's this pathway that we have, sort of a natural anti-inflammatory pathway that involves aryl hydrocarbon receptor. And when this transcription factor is engaged, it actually leads to a series of anti-inflammatory effects in the skin. So there's a decrease in inflammatory cytokines, there's an increase in antioxidant response, and an increase in barrier protein function when AHR is engaged. So the drug, tapinarof, is portrayed here in the purple as TAP, is actually a small molecule that engages this normal anti-inflammatory transcription factor, if you will. So it engages that AHR, and then that goes on to lead to the anti-inflammatory activities of the drug. So kind of a completely new way of tackling psoriasis, interesting mechanism of action. And by the way, this pathway is an ancient pathway. It's evolutionarily conserved. Insects, for example, have AHR that act as a normal defense within their bodies as well. Clinical trial results, this is phase 3 studies, and here we're looking at the percentage of patients who are clear or almost clear after 12 weeks of applying this new cream. And so we're getting results in the 35 to 40% range of clear or almost clear skin with tapinarof cream. You might say, well, that's not great. That's to me, this is a very impressive results. It's always difficult to show deltas from the vehicle creams and pretty much many psoriasis, many dermatology studies. So actually getting that delta is really important, and here we see a wonderful, nice delta. I'm not going to show you the slide, but the other feature of this cream is that when we went on to long-term use, past 12 weeks, we had a study designed where patients could be on it for a month and then off it for a month or off it for several months. So it was dependent on if they had residual disease. And the people who cleared and then went off it for a month, they could stay off the drug for up to 4 months on average before needing it again, which is really different than what we see with topical steroids, where we see disease recur much more quickly. So the words remittive effect have been used for this particular new cream for psoriasis, tapinarof. So hopefully you'll have some success with this with your patients. Then we have roflumilast. Now we know this mechanism of action because we've had apremilast orally for psoriasis, and then we've had crisaborole topically for atopic dermatitis. Both of those are PDE4 inhibitors. Roflumilast is actually a more potent PDE4 inhibitor compared to both of those agents, compared to apremilast and compared to crisaborole. So we have a more potent PDE4 inhibitor in a topical formulation, also looking very good for psoriasis. And here's the week 8 phase 3 results. And here again, we're looking at IGA success, which means clear skin or almost clear skin at week 8. And we're in the 37 to 42% range with this new topical PDE4 inhibitor. So those are the two main ones that I wanted to talk about. So the bottom line here is we have more and more interest in promising, safe, and effective non-corticosteroid options. One that's been being talked up as having a remittive effect as well, might not require continuous use over the long run. So to me, some nice advances. Now we go to the much longer list. And when I give these talks, one of the biggest things that everybody asks me over and over again is, I'm overwhelmed. There's too many. How do you sort it out? What do you use? Just tell me the one you use. There's 11 biologics now for psoriasis, a 12th one coming, and 5 oral options, or 4 oral options with 1 coming soon. So I'm going to try to take you through my thinking on these drugs and sort of how I rank them. And of course, I get criticized for ranking, but that's what you want. That's what people want. They want to know what's best. They want them ranked. And so to me, it's not such a big deal because it's numbers. And I'm a data guy at heart. And if a number is better for one drug or the other, I'm going to say that drug is better. Okay. So we're going to go back a little bit to the science of psoriasis. I've been showing this slide for years, and I update it. That's because I went to medical school in the 1980s, so I'm an old guy now, when psoriasis was a keratinocyte disease, and methotrexate, ultraviolet light, retinoids were used. And then I was around when we started thinking, oh gosh, cyclosporin. Cyclosporin is an immunologic drug. It's an immune suppressant, and it's clearing psoriasis. So let's think, oh gosh, psoriasis is an immunologic disease all of a sudden and not a keratinocyte disease. Another big thing that helped with that is the development of immunohistochemistry, actually showing T cells by staining in psoriatic tissue. Because if you just kind of look at the far view of psoriasis, all you see is this dominant epidermis, right? The epidermis is thickened, it's scaly, and it's the main histologic feature of psoriasis. But when we started typing the cells, we found that it was packed with T cells, especially the upper dermis. The upper dermis of psoriasis is packed with CD4 positive T cells, CD8 positive T cells in there as well, scattered through the epidermis. So as we've learned, the bottom line is it is an immunologic disease. And as our sophistication developed from Th1 to now Th17, we've hit the jackpot. We've hit the jackpot because now everything that's working really, really, really well in psoriasis is targeting that IL-23, Th17 pathway that I started with. So as you can see, everything kind of that is new is all targeting that pathway. There's a reason for that, because the drugs work so well and they're so safe. Now, another way of thinking of this is that if you target broadly a broad immunosuppressive drug, more like cyclosporin or methotrexate, to me, you have safety concerns and or less efficacy. If you go more narrow and target more inflammation-specific drugs, like TNF blockers and apremilast, you have fewer safety concerns and more efficacy, often. But then when we target more psoriatic inflammation, so not inflammation in general, like TNF blockade, but psoriatic inflammation, the type of inflammation seen in psoriasis, what we get is a high efficacy and a high safety margin. And for some of you older folks, perhaps, like me, we grew up with, oh, if you get more efficacy, you're going to have more safety concerns. Because that was the case for methotrexate and cyclosporin and retinoids. We push the efficacy, we get more safety problems. It is not the case with 23 and 17 blockers. We actually see that these drugs are much safer. And the reason, again, is we're hitting this specific target, this mucocutaneous defense system that's upregulated or elevated in psoriasis. Diagrammatically, a way to show this, prednisone, cyclosporin, broad immune suppression. You have partial immune suppression with TNF blockers, not as bad as cyclosporin or prednisone, yet you have very narrow or specific immune suppression, at which I don't even use that word. I don't use the word immune suppression with 23 and 17 blockers. I say that they're immunomodulatory. And the reason I don't say immunosuppression is that there's no evidence that these drugs are suppressing the immune system in the classic sense of prednisone and cyclosporin. So there's no lymphomas, there's no SCC to BCC flip, that kind of thing. There's no serious infections as well with 23 and 17 blockers. So hopefully this helps you kind of think about TNF blockers, the older biologics versus the newer ones. So now I'm going to get into some specifics. So this is a take-home slide, actually. This is an important one. Ranking TNF blocker efficacy. So we have 4 TNF blockers. And to me, on balance, certolizumab is your best choice if you need to use a TNF blocker. On the other hand, second bullet point, all IL-17 blockers and all IL-23 blockers are more efficacious than all TNF blockers. So you take the best TNF blocker, it's still not as good as the 17 and 23 blockers. So for skin-only patient, I do not recommend TNF blockers. I haven't for years now. They're not the drugs that I would want to be on. They're not the drugs that I would want to put my sister on, my mother on. I don't use TNF blockers for skin-alone patients. Psoriatic arthritis, a little bit different. So this is where I prefer IL-17 blockers, but if you look at the data in joint disease, 17 blockers and TNF blockers are really comparable. And they both look slightly better than IL-23 blockers. So if you got a patient with bad joint disease, yes, you could use adalimumab or certolizumab, but my preference would be ixekizumab or secukinumab, an IL-17 blocker, because you have equal efficacy in joints, it's a safer class of drugs, and better efficacy in the skin, okay? And then regarding safety, I've already said it, you already know it from my previous slide, all IL-17 and IL-23 blockers are safer than all TNF blockers. We don't have any of the baggage of the TNF blockers. No serious infections, no tuberculosis concerns, no MS concerns, CHF, no hepatitis B reactivation concerns with 23 or 17 blockers. Okay, now, I've told you I like 23s and 17s, and the reason why, right? So what about those two head-to-head? 23 versus 17, Dr. Blauvelt, what's your favorite group? Well, I think they're both great. There's a little bit differences between them. I think of this as targeting downstream and upstream. I'm going to just kind of put a picture here. So this is an Oregon waterfall about 45 minutes from my house. This is my daughter and her husband. And I've been showing this slide for years. And the way I like to think of it is if you're blocking IL-23, it's easier to block psoriasis. You strategically put one kind of rock at the top of the waterfall and everything else falls away downstream. Or you cut the head of the snake. With IL-17 blockers, you're midstream blocking and you're still getting IL-23. You're still getting water coming over the top of the waterfall when you're blocking with an IL-17 blocker. It's still a terrific treatment. It's still a great way to block psoriasis. I said they were my best choice, my favorite choice for psoriatic arthritis. Okay, so here's the ranking. This is another bottom line. Remember this slide, if you will, kind of important information. And this is synthesizing years of clinical trials, many clinical trials that I'm not going to go into, and head-to-head studies. I have risankizumab as the best IL-23 blocker, followed closely by guselkumab. Those are my two favorite IL-23 blockers. They're very similar. The data are excellent with both of those drugs. You can't go wrong if you're using either of those drugs. In terms of IL-17 blockers, we have ixekizumab and brodalumab as the best IL-17 blockers. The caveat with brodalumab, that's the drug that has the suicide warning. So I prefer ixekizumab as my IL-17 drug of choice. And then if you look at between them, some IL-17 blockers are better than some of the IL-23 blockers and vice versa. So I'm not going to give you a final ranking, but I'm going to show you in the next slide just kind of how others have tried to rank this group of biologics. They're both really safe. The IL-17 blockers have thrush associated with them in low percentages, usually 2 to 4%. They have rare incidences of IBD. So patients who may have IBD, you want to avoid an IL-17 blocker for sure. Okay, now, Dr. Blauvelt, what about patients that have cancer? What about patients who have HIV? What about those who have hepatitis B, hepatitis C, on and on? My answer is that IL-23 blockers are the safest class of systemic drugs we have for psoriasis, including apremilast. IL-23 blockers are the safest drugs we have for psoriasis, based upon long-term safety data of essentially no side effects. But Dr. Blauvelt, there's side effects reported in the cases. There's no signal over and above what we would see with the placebo control group for IL-23 blockers. So in all difficult situations where patients may be immunocompromised and you have to treat with a biologic, use a selective IL-23 blocker. Now, there's been a lot of meta-analyses, but they basically support my ranking that I just gave you. This one just came out. To me, it's kind of I'm biased. I'm the first author on it, but I think it's a fun way to categorize the drugs. We looked at the number of days in a full year period that patients were experiencing PASI 90 or the number of days experiencing PASI 100. And here we see ixekizumab coming out on top for PASI 100, then risankizumab. If we go to the PASI 90, we have risankizumab and then ixekizumab. So the 4 drugs that I told you were my favorites, they are the 4 here as well, and they are also the 4 that come out in other meta-analyses of all the data that we have. Okay, so I'm going to talk about some new drugs now. Bimekizumab. So bimekizumab is another IL-17 blocker that the bottom line is I think it's going to go to the head of the class. So this is the drug where we've seen the best efficacy to date of any drug we've ever tested in psoriasis. This is the one. It's not out yet in the US. It's been approved in Europe. It's been delayed. And the reason I think it's so efficacious is that it blocks IL-17A and IL-17F, another pro-inflammatory cytokine. So this is what you need to know about F, IL-17F. It's 50% homologous to IL-17A. It's also abundant in psoriasis lesions. It's pro-inflammatory, just like IL-17A. And the drug bimekizumab blocks both of these types of IL-17, IL-17A and IL-17F. And it does it by blocking a region that's shared by the 2 cytokines. So a homologous region of these 2 cytokine types is blocked by bimekizumab. Here are results compared to adalimumab, which is in red. And you can see it kind of blows it away no matter what measurement you look at. Here is ustekinumab, a little bit better comparator. It still blows it away. Ustekinumab is in red. Bimi is in green. And here is compared to secukinumab. So this study is interesting because it's an IL-17A blocker versus an IL-17AF blocker. And in red is secukinumab. And it's pretty close results, but when you look at the PASI 100, which is the upper left, you see PASI 100 rates close to 70% with bimekizumab and about 50% with secukinumab. So when we look at high levels of response, PASI 100, that's where you see separation with this new drug. And then it works over time. It's durable. It stays working over a 2-year period. That's all the data that's been released publicly so far. It works in psoriatic arthritis as well. We're going to have phase 3 data released actually this month. This is phase 2 data showing that it works really well in psoriatic arthritis. It has safety similar to the other IL-17 blockers. So we're seeing thrush here. The difference is the number is 15%. 15% of patients getting thrush. Again, This is a pathway normally involved in controlling yeast in our bodies. So if we knock down this pathway even more, we're going to see more yeast. It's almost always in the mouth. We don't see vaginal candidiasis. And it's very easily treated as well. I just simply give, fluconazole. Fluconazole, 200 milligrams once a day for 5 days. And that seems to be fine for most patients. It doesn't keep them from being on this drug. We also see the rare IBD signal as well, about 1 in 500, similar to what we see with the other IL-17 blockers. So this is the expected kind of results with the safety of this drug. So it has excellent efficacy, slightly higher than the best biologics currently on the market, especially PASI 100. It's good in PSA as well. All right, we're going to switch now to deucravacitinib. I'm running out of time. I got to go a little faster. Deucravacitinib is a JAK inhibitor that inhibits the JAK protein called TYK2. And I'm going to talk about TYK2 here now. So TYK2 is one of the 4 JAKs. There's JAK1, JAK2, JAK3, and then TYK2. Don't ask me why it's not called JAK4. It's not. It's called TYK2, but it is one of the JAKs. It's different than the other JAKs, though, in that it's more selective to inflammation as far as its signaling goes. So the other JAKs are involved in more broad biologic processes. So when we block those JAKs, we get more side effects than when we block TYK2. Another interesting thing is there are people walking around without TYK2 function, and they're relatively protected against getting psoriasis. So this natural experiment out there, if you don't have good TYK2, you don't get psoriasis. And they're not at increased risk of serious infections, so that's a good thing. So here is the gene mutation. It's a G to C switch at position 1104 in the TYK2 gene. If people are heterozygous with that mutation, they're slightly protected. But if they have the homozygous polymorphism, if they're CC, they're not only protected from psoriasis, but ulcerative colitis, MS, Crohn's, and ankylosing spondylitis. So real kind of interesting natural experiment. This is a little bit complicated, but I would just want to, you guys probably have seen JAK signaling pathways. So the important thing to remember here is that this drug, deucravacitinib, blocks signaling of IL-12 and IL-23. You think, well, we have a drug that blocks IL-12 and 23. That's called ustekinumab or Stelara. So we have a biologic that blocks those same 2 cytokines. Some have called this the oral version of ustekinumab because it blocks 12 and 23. So it's a small molecule inhibitor. It blocks signaling a little bit downstream from blocking the cytokine. So it's going intracellular and blocking TYK2 and blocking signaling of these 2 key cytokines in psoriasis. The other important thing about the drug is that it blocks TYK2 in the regulatory domain of the enzyme. And why is that important? Because most JAK blockers, JAK inhibitors block in the enzymatic domain, the orange part, and there's more inhibition of the other JAKs when we try to target the enzymatic part. And so by hitting the regulatory part of TYK2, we're avoiding blocking JAK1, JAK2, and JAK3. Really important for safety, right? We don't want to block the other JAKs. We want to just block TYK2, and this is the strategy for just blocking TYK2. So here are phase 3 results for deucravacitinib. Because it's a pill, taking once a day, The comparator was apremilast. So of the 15 drugs that I showed you at the beginning, 11 biologics, 4 orals, apremilast is ranked 15th. It's the worst drug we have in terms of efficacy, in terms of numbers. So here, the target is a little bit easy, if you will, but it's a leading drug oral treatment for psoriasis. So we have deucravacitinib in green and apremilast in red. And this is PASI 75 results. And if you remember numbers from the biologics, the numbers we're seeing here for deucravacitinib are similar to what we saw with etanercept and with adalimumab. Okay, so it's not comparable to the 23 and 17 blockers, but it's about comparable to some of the worst biologics, if you will, that we have on the market now. It continues to work over 52 weeks. It also seems to work in psoriatic arthritis. Not surprising based upon sort of the mechanism of action here. So this is phase 2 results. Needs to be confirmed in larger studies. So the bottom line for this new oral drug, we have good efficacy, but less than most biologics, but better than oral drugs currently on the market. Seems to be effective for PSA. I didn't highlight it, but the safety has been good. It has not looked like the other JAK inhibitors that we're using now for atopic dermatitis, alopecia areata, and vitiligo. And it makes sense based upon the mechanism of action. So we have a slight increase in herpes zoster, a small signal there, but no other sort of things that we're seeing with the JAK inhibitors, and no blood test problems as well. I think this drug is going to get approved in the fall of this year. So this one is coming very soon to a pharmacy near you as well. Okay, so bottom line, we have great choices now, better options for oral therapy and better options for PSA to come. How much time do I have? Am I out of time? Okay. What is missing? What do you think is missing? We have great treatment of psoriasis, right? We can clear people safely now. 2022, you don't have to live with psoriasis. You really don't, if you have decent insurance, right? It's all about the insurance and getting these drugs. But it's not a problem with the drugs. It's a problem with access right now. Well, what's another problem? The other problem for me is we have to keep using these drugs. They're treatments. They're not cures. So we can safely clear psoriasis, but we need to go after the C word, right? We need to try to go to the next step to get rid of psoriasis. So I'm going to tell you about a few strategies here in the last few minutes. One of them is to go after resident memory T cells. Resident memory T cells are T cells that are found in psoriatic lesions after the lesions have cleared. After everything is gone and we can't see anything anymore, resident memory T cells are found in psoriatic lesions, and those are the cells that are responsible for recurrences of psoriasis at the same spot. This is why psoriasis goes back to the same spot. It's these cells that get reactivated in the absence of drug. So that makes you think, right? How can we go after TRMs then? Let's try to go after TRMs. So there's some strategies here. One of them is what we call hit hard, hit early. And the idea is if patients have new onset psoriasis, the TRMs might not have set up shop, if you will, or not established themselves in the tissue as much as if you had chronic psoriasis. And so you're trying to get at the disease earlier, knock it down. Perhaps you can you can get at it that way. The other thing is that there's some evidence that IL-23 is needed for TRM survival. So we have IL-23 blockers, right? So can we get at TRMs by manipulating IL-23 inhibition in some way to make it even better than what we have now? So there are strategies out there, and maybe have me back in a few years, and maybe we'll be talking about the results of these studies. But this one is using secukinumab in people with new onset psoriasis. So you have to have psoriasis less than 12 months to get into the trial, and then and you're being treated with secukinumab or light therapy, and then they stop after 1 year, and they follow patients. And the idea is that maybe 1 year of secukinumab in an early onset patient will be disease modifying compared to ultraviolet light. So that's the idea behind that study. This is a complex slide, but basically the bottom line is, last year I was involved in this paper where we showed that guselkumab, an IL-23 blocker, can knock down TRMs and not secukinumab. So 23 blocker could decrease TRMs, but a 17 blocker couldn't. And that was shown in this paper. And then if you go backwards to the phase 1 study of risankizumab, an IL-23 blocker, these patients got 1 IV dose, and basically 46% of them, 6 of them, were still clear of their psoriasis up to about a year after a single dose. So the idea I'm trying to get at here is sort of normal dosing, we can knock down TRMs, but this is super high dosing, and maybe we knock down TRMs a lot with this single high IV dose, right? And we do know that when we withdraw risankizumab, it's associated with the longest disease-free intervals after stopping drug. In particular, the best IL-23 blocker, we can knock down, we can remit psoriasis longer, right? So that takes me to this slide. This is a study that we just started at Oregon Medical Research Center. This is my study. This is my idea. We're called it the knockout study, and we're treating patients with 600 milligrams of risankizumab. That's a 4x dose, and we're treating at 0, 4, and 16, and then we're stopping. We're trying to hit it over the head hard, get more at those resident memory cells, and then seeing if we can induce remission for even longer than what we see with regular dosing. We've dosed 9 patients so far, absolutely no side effects, no AEs so far. Almost everybody's at 0 of the 9 people. I mean, it's really exciting to me. So we're trying to take what we have, maybe use it in a little different way to maybe have a bigger impact on psoriasis. I'm running out of time. This is another strategy. We knock down disease, in this case, ustekinumab, and then you try to induce tolerance with abatacept. This is Jim Kruger's study. It was just published. So unfortunately, it didn't work. But I love the idea of knock down the psoriasis. We can get rid of it. We can clear it. But try some strategies then to keep it from coming back. And this was a strategy. So I like this kind of design where you might see the design of knocking down psoriasis with our really good drugs and then stopping that drug and trying to induce T-cell tolerance or something like that. Another kind of type of strategy is to expand Tregs. So you knock down psoriasis, then you expand regulatory T cells to kind of help the psoriasis from coming back. 23, receptor blockade. So there are people that are walking around with IL-23 receptor polymorphisms that are protected from psoriasis. Can we utilize this genetic information somehow? We do have CRISPR now. Can we knock out IL-23R? Can we knock out IL-23R in psoriasis patients, stop 23, and basically cure psoriasis? So those are my ideas. I dedicate this talk to my dad. He had severe psoriasis before biologics, suffered a lot from the disease. I'm just happy we have such great things now. So thank you.
It's a super kind introduction. Thank you, Dr. Fernandez. I'll say that it is such a pleasure to be here. I appreciate everyone's attention. I understand I am the last stop between lunch and this session, so I will try to make this as interesting as possible. I've planned about 35 minutes of slides and about 10 minutes of discussion, but I've done these so much I can probably get through them a little quicker. So first thing, we got to get on the same page. Similarly, I think cardiometabolic disease, when I was training, was called metabolic syndrome, but here we now call it cardiometabolic disease. Why? We want to capture more people that we say have cardiometabolic disease rather than metabolic syndrome. So it's diseases of the blood vessel, diseases of glucose metabolism, obesity, high cholesterol. So when you have a psoriatic patient in front of you whose BMI is higher than 27 or 30, you can simply say you have the beginnings of cardiometabolic diseases. I'm going to start, I have 3 preventive cardiology practices around the country, and I still actively see patients. It's my favorite thing to do, besides research and hang out with my kids. So my history, this is a true story. This was 5 years ago, and I tell this case every time I can because it really shines a light on how we're all missing a huge, huge opportunity to intervene and make comorbid diseases go away later in life, and living a 50, 60, 70-year-old sort of life that is free of comorbid disease. 44-year-old female. She actually came to me because her best friend from high school had gotten stented a couple weeks back. She had borderline hypertension, not treated. She was not treated for her psoriasis. She was on no medications. Mom had a family history, Mom had diabetes, so that puts her at risk for diabetes by about 35%. Father had a myocardial infarction history at 54, puts him at risk for about myocardial infarction, puts her at risk by about 25%. So just the genetics alone here, you got to keep that in mind as you're looking at the patient in front of you. She smoked half a pack per day of cigarettes. No other complaints, cardiopulmonary. I don't know if the red transmits well, but I've highlighted her general medical exam to show you she has diastolic hypertension. She has a BMI of 32. She's a waist to hip ratio of 1, sort of like an apple-shaped rather than a pear-shaped. A lot of central obesity in this person. And she had 9% of thick plaque psoriasis on her elbows and knees, so a solid moderate. Here are her labs, and she came in with these from her outside physician, and I'll tell you, this is not uncommon. Everything kind of looks okay. If you were going to say, hey, get out of my office if you wanted to have a early departure day, you could say these are all passable by the guidelines, but that's not what we're here to do, right? What we're here to do is tell our patients this is a wake-up call. So what's wrong with these labs? Total cholesterol is just a little bit high. It should be under 200, but we have to fractionate it. The LDL is 159. It's not over 160, so it doesn't quite qualify for statin therapy. Triglycerides are high, 200. They should be 150, but nobody treats primary hypertriglyceridemia without another reason. And then the HDL is 40, should be 50 in a premenopausal woman or higher. So all of these are just a little bit abnormal, okay? And that's going to be sort of the theme for my talk here is everything's just a little bit abnormal. Is it enough to trigger doing something different for the patient? Her fasting sugar is 116. That's awful. For a 44-year-old, she'll have diabetes in 10 years. No joke, WHO, decode genetics, follow people with a fasting sugar greater than 110 for 7 years, they will have diabetes in 7 years during that curve of life. I added a slide today for you. Her HSCRP was normal, so do not leave this room thinking CRP is great. in psoriatic cardiovascular disease. Okay, if I've done one thing for you guys, it's remind you, do not get fooled by a normal CRP. The IL-6 burnout in this disease is so high, we don't see high CRPs. So by primary prevention guidelines for cardiology, she could get a pat on the back and get out of your office. My goal today is to not have you guys think that way, okay? So she's 44. She's untreated moderate psoriasis. She's the smoker. She has a family history of CAD. She has high blood pressure. She's obese, and she has prediabetes. When I frame it like this, I think most of us would be hit on the head with a hammer saying, do something for this patient. The sad part is that as a preventive cardiologist doing this now for almost a decade exactly, I've been at the NIH a decade, we still don't know the answer to this question. What's her cardiovascular risk? Well, just for the sake of time, I'm going to breeze through this, but it's basically a simple regression based on age, lipids, diabetes, and smoking. Total cookbook medicine. Cardiology loves cookbook medicine, right? Plug, chug. What do you get when you plug and chug for her? 9%. Yes. She's low risk, I can go, right? That's what that means. She's low risk, we can get her out of here. So not true. The beginning of this talk has to be you waking up and being like, these are missing patients. And who? Young psoriatic patients. I put in one extra slide today. This is from a colleague in Spain, Alvaro, Dr. Cantaro Gonzalez, who actually runs a Spanish cohort study alongside of me at the NIH in Spain. And what he showed here was even when you uptick these people's risk scores, we're still missing people with coronary plaque and femoral plaque, meaning our risk scores stink for these diseases, okay? So what do we need to do? We need to first start. I love that I'm following Andy here because he gave you everything you need to know about those cytokines and how we're picking them off one by one. So what about our inflammation associated with psoriasis? So first of all, I love that Andy brought up the concept of psoriatic inflammation. It's different. It's different than RA inflammation. It's different than lupus inflammation. And now that I've spent a decade doing this, I truly, truly believe there's something different about this. I'm going to go back. This slide's now 20 years old. And it says that when you have a high CRP and you're a healthy functioning person in the Women's Health Study, you have a 4-fold risk of future heart attack. Okay, so that means you have nonspecific inflammation, that's high, and you have a heart attack. So this started a huge, huge field that culminated last year with these beautiful 5 Kaplan-Meier curves. When you have had a heart attack and we treat your inflammation, you actually don't have a second heart attack. Wow. So that means that treating inflammation for secondary prevention in the world works. But then why wouldn't we adapt that to our psoriatic care, right? So what I've spent my 10 years doing here is just dedicating my time to figuring out why these thick, scaly plaques that you're all oh so familiar with in the upper right here, why are they driving cardiometabolic diseases, okay? So I'm not going to go through this. Most of us here are familiar with this, but that third bullet is what the NIH really sat on in 2011 when I pitched the program to them, that this is a physician scientist's most rich source of information, 1 billion immune cells accessible to biopsies, skin lesional biopsies, non-lesional biopsies, and we can understand what's happening over time. So before someone sells you a bridge, you should at least ask them for the data, right? Do I have ownership of this bridge? Well, I'll tell you, it took us a long time to get this accepted. So over a period of about 8 years and 100,000 patients of epidemiological studies, Joel Gelfand and I first showed that there's increased myocardial infarction in psoriasis. And when you look at that red arrow, it's the younger, more severe patients. So we have a window of opportunity between 40 and 50 in severe psoriasis. That is the steepest point of curve for MI, and the data I'm going to show you are going to explain why that's the case. There's 5 years of life lost. What are the 3 most common reasons why the life lost? Number 1, cardiovascular disease. That's why I'm here. Number 2, infection. Number 3, cancer. So there's clearly an immune signature here that's driving these comorbid diseases. And finally, in the bottom left, I just show you sort of the hazard ratios that when you adjust for cardiovascular risk factors, you still have anywhere between a 40 and 60% increase in the first MI stroke or dying from your heart attack when you have psoriasis. So this is a conceptual model. This is courtesy of, one of the first grants I wrote in psoriasis. And it's saying that, look, when you have psoriasis through immune activation, systemic inflammation, and lipoprotein dysfunction, you get this horrible tombstone myocardial infarction in about 1 in 4 patients. So 1 in 4 of your patients will have some form of heart disease. That's a super powerful statement. So how have we gone about this? I'm just going to spend a few minutes on this slide because it's important. In 2012, we started the Psoriasis Atherosclerosis Cardiometabolic Disease Initiative, PASI for short. I named it PASI based on the PASI score. Thought it was cute, thought it was funny. It would garner some laughs. No one ever laughs at the joke, so I'll just still call it the PASI study. It's fine. But we follow people for 4 years. We just got funding to stay open for 10 years. So we're following 400 patients over 10 years with the hope of making a psoriatic Framingham risk score. What do we do? So we believe in deep phenotyping. Everybody will get a PET CT, a PET MR, and a coronary CTA at each of these green visits. And then we're saying hello via telehealth during these visits. Everybody gets blood. If they would like to, they can get their tissue sampled for adipose and skin biopsy, lesional, non-lesional. So here we have a large catalog, if you will, of psoriasis over time. We compare that, and this should have another box here. I'm sorry, we've now just gotten funding to do the follow-up studies, but we have funding to bring in healthy diabetics and coronary patients, 100 each, and we follow them with the same exact markers. So what I'm about to show you is contextualizing psoriasis to healthy, psoriasis to diabetics, which we're underpowered for, but we can still do it, and psoriasis with coronary disease. I think the most important next 3 slides are just to have you understand what happens at baseline in these diseases, because I promised that I would talk about treatment effects, and I don't want the talk to go on too long without getting to treatment effects. But these next 3 slides are very important. The first one is when you think of systemic inflammation, I think Andy said it best, it's psoriatic inflammation, but we can detect it in the blood. And so how? When you look at someone with psoriasis in my clinic, walking in, 120 of them, comparing them to those who have heart attack. Remember, we were just told that I still see patients, so I see heart attack patients about once every quarter. And so this is 100 of those. And then coming into the ER are those coming in with chest pain, but they end up not having cardiac chest pain, so we'll call it non-ACS. So your controls are all the way to the right. The TNF-alpha levels when you're having a heart attack are about 2.41. But when you're walking around with psoriasis, they're 9 times higher. So if I told you that psoriasis resembles a heart attack, now you'd understand why I'm saying that. This is a very, very inflammatory disease. Secondly, when you look at the inflammasome, or real canonical early signal of inflammation, it's higher in acute coronary syndrome. This is why the CANTOS study worked in the middle. But it's 5 times higher when you're walking around with psoriasis. So psoriasis is as inflammatory as having an acute coronary syndrome. We haven't published this data because I'm not sure what to make of it. But I know that as dermatologists and healthcare providers out there, you'll know now when you look at a psoriatic patient with severe disease, you're going to say, whoa, you have as much inflammation in your blood as someone who's having a heart attack. Second, what happens with all that inflammation? Totally jacks your lipids. So this is, if you took a test tube and you shined a flashlight through that test tube. This is nuclear magnetic resonance spectroscopy. And on the left, you'll see that normal lipid panels go from a density, so high density lipoproteins right here, and then you have this density here in the middle, which is your intermediate dense lipoproteins, that's your triglyceride, and then you'll see you got these LDLs, and what happens in psoriasis, you have this ApoB shift. The body stops making HDL. It stops making ApoA. So remember our patient, HDL was low, but her ApoBs were high. Her triglycerides and her LDLs were high, but not high enough to warrant treatment. This is the paradox. We need to do something about this. But this shows that simply walking around with psoriasis modulates your lipid composition to take away the protective ApoA and drive in ApoB. So you're actually creating heart disease very early on in life. Finally, I eat an egg. It has 80 milligrams of cholesterol, okay? My HDL works fairly well. I've tested it, and it works at a point where if I put in X, I usually put out about X minus maybe 1%. What I'm showing you here is HDL has the process of reverse cholesterol transport, where a macrophage loaded with lipid can get visited by a nascent HDL, esterify that cholesterol, and dump it into the poop, into the bile, right? So that's reverse cholesterol transport at its best. My first discovery in 2012, after we'd proven the epidemiology, was actually HDL in psoriasis works 8 to 10% less efficiently. You may be like, that's BS. Like, forget that. That's nothing. Count up the cholesterol you eat in one day and make it easy. 200 milligrams. The psoriatics are holding on to 16 to 20 milligrams of cholesterol extra per day. Think of the chronicity of that from when they're this big, right? And if they happen to have it when they're this big, they're going to have chronicity there. So this is driving not only the ApoA going down, but the ApoB going up. But this is driving less of it going into the poop, more of it going into the tissues. Could be that it's going into the skin, for all we know. Could be driving the disease more so. So dyslipidemia and fat are the two biggest new actors in this game. So it's usually now that I stop and I remind you, this is a talk about psoriasis. I am a cardiologist, but this is important. It's a common disease. It has waxing and waning features. They develop CVD between 30 and 40, and I'm going to show you that data. That's scary. I'm 45. If I had CVD right now, I would be worried. And we don't treat our psoriatic patients like that. And then what Andy just hit on really nicely, immune activation, reversible with a broad range of therapies. When I got to the NIH, people were like, what is he doing studying psoriasis? Single cytokine inhibition is possible with FDA-approved therapies. Boom, right? So now, this is the fun part. I now am going to show you the pictures that I take. I've spent a decade spending taxpayer dollars as a public health servant taking pictures of blood vessels. And you're going to hopefully enjoy this because you guys are all over the skin. You guys have whole body knowledge. But let's look at the blood vessels together. So what did I develop? I developed a whole body vascular phenotyping program at the NIH, starting on your left with FDG PET-CT and FDG PET-MR. What FDG is radiolabeled glucose. We know it from metastatic oncology literature for finding the metastatic lesion. But here, what we discovered in 2006 was when you give an oncology patient FDG, those with atherosclerosis were actually getting uptake in the vascular wall. So we followed that. When I got to the NIH, I added an MR detector to it, so you're going to not see the data today, but you'll see we can do functional consequences. So I'll go through some of my FDG PET-CT data. But what you should remember is go to where the money is, right? So Willie Sutton was a bank robber. He used to say, why would you rob a convenience store when you can go to where the money is, right? So go to the coronaries. So the second thing I did is in 2014, I added a coronary phenotyping program, and it was probably the best move that I'd ever made for the program. Okay, so FDG. Most of you have probably heard that it picks up, sort of active glucose in cells that are actively metabolizing. So it's a biomarker for CD68 positive macrophages. We've shown elevations in vascular inflammation actually predisposed to coronary events. But I'm going to just spend a minute here on these two images. These made it to the World Health Organization in 2014 to redefine psoriasis as a serious autoimmune disease. So the WHO called me up and said, can we use these? Can you explain them? Can you capture them? So this is a control. They get radiolabeled glucose in, the heart takes it up, the kidneys excrete it, and the bladder goes out. Compared to psoriasis, you see this heterogeneous uptake. You see skin uptake, joint uptake in someone who doesn't have psoriatic arthritis, abscesses, liver uptake consistent with the psoriatic liver. And lastly, you see this vascular inflammation, which I'm going to show you on the right. So when you look at this tomographic CT, you just see this heavy amount of vascular inflammation. And what we showed, I was not on Twitter at that time in 2016. But this was a very highly tweeted picture because for the first time, our psoriatic patients felt what they see on the outside is what they're feeling on the inside. And so here you have PASI scores on your x-axis, and you have vascular inflammation on your y-axis. And the more severe the psoriasis, the more vascular inflammation. This is going to be a theme that comes up again. We'll get back to it. So I was asked to talk about treatments, okay? And I think you've gone through every biologic and how it works with the prior talk. I'm not going to go through that here because we only have a limited amount of time. And what I would like to do is actually give you a top line of what's available out there. And I'd like to move to the coronaries, right? So we started the program for 8 years doing psoriatic trials evaluating therapies on aortic vascular inflammation. There are 4. We just late broke the last one at AAD. I won't go through the results of that one. You can ask me questions if you would like. But each of these was basically asking, what if you took a biologic versus not, what would happen to your vascular inflammation? And people are like, wait. You're treating the skin disease, but you're following the heart disease. I need you to suspend your disbelief and listen. It actually works. There's something about dropping inflammatory burden in the skin that improves vascular health. Haven't figured out why. Might take another decade, but it works. What the study design on all of these is we screen them. You've got severe psoriasis, you're ready to go on a biologic, you have all the exclusion criteria that are not going to stop you from a biologic. And then we put you on, and look, I'm just doing 4 studies in one, but we put you on adalimumab versus placebo, UVB versus placebo, secukinumab versus placebo, ustekinumab, and apremilast, okay? So you get the drift. And then we image them at 0, 16, and 52 weeks. So actually get 3 sets of images. These are rigorously controlled randomized trials, and in the last case, it was an open label study. If you're interested in the results, I feel like this is like one of those like cliffhangers, right? If you're interested in the results, I would urge you to look at the paper that I've cited on the bottom left. It's basically just a coverage of all of our trials in the JID. But what I've done is I've kind of put it in there in ugly writing. The strongest reduction in blood-based biomarkers was observed with anti-TNF therapy, adalimumab. And phototherapy. Gotta love the phototherapy. Gotta love the phototherapy. Improves HDL, improves visceral adipose tissue. Only phototherapy improved lipids. Only ustekinumab improved aortic vascular inflammation. None of them improved insulin resistance. So you could be like, wait a second. You're telling me to treat their psoriasis, but these things are sort of like neither here nor there. First thing I'll say, doesn't matter. Every single treated patient experienced an improvement in their psoriasis severity. What does that lead to? An improvement in quality of life. Second, every single psoriatic patient who went on a biologic improved their blood systemic inflammation. These trials are between 50 and 80 people. How many trials do you need to show that treatment with an anti-inflammatory actually leads to a decrease in inflammation? So I'm not concerned about that. I do believe the most exciting part of this is there was no harm. There's no worsening of vascular disease. We're actually improving things that lead to vascular disease later. It was right around that time that I had incorporated the coronary phenotyping program in, and we saw this. Someone came in on one of our post-MI studies, and the vascular inflammation looked exactly like psoriatic inflammation. And we said, wait a second, so if psoriasis and cardiovascular disease share these pathways, can we look at the coronaries? So from here on in, I'm not going to talk about FDG PET. I'm not going to talk about FDG MR. I'm going to talk about coronary arteries. Why? We're at a point now where if the surrogate itself has shown benefit, and you know that the coronaries are not a surrogate, they're the actual vascular bed, we have shifted almost 90% of our interest into this, and why. So I'm going to show you what we do. If this plays smoothly, I can sort of narrate around it. We have 2 of these CT scanners at the NIH. There's a 320 of a Force and a Toshiba. Manufacturer doesn't matter. Our usual scan, so a lot of early concerns were, that's a lot of radiation. Our usual scan is about that of a couple chest x-rays, and we do this very well. And we do it very well because we know how to limit contrast and we know how to limit the field of view. We then digitally subtract all the osseous structures, all the myocardium, and you're left here with the ACC 17 segment model of coronary disease. You'll see that I have the blue highlighted. That's the LAD. That's the artery that actually is the most important in most people's coronary circuitry. And what we do then is we stop that, and then we'll go for each coronary. There are 3 human coronary arteries, the right, the left, and then the circumflex. And we then look at it. So look at my finger. Now, after you've resolved it, you get a front, a back, a side, and a side. So on the right, if you look really closely, there's 2 contours here. And what we're doing is we're actually getting, so you'll see here, there's a mixed proximal calcified plaque, mixed calcified, mixed non-calcified. There's another mixed non-calcified plaque down here. And so the patient's not going to have symptoms. They're going to be like, what are you talking about? I don't have heart disease. Well, in fact, when you look at the CTA approach, and published in all the right places, so if I do point you to, do people believe this? This is the European Heart Journal, this was Circulation, this was Cardiovascular Research. They've all sort of figured out that if we get the luminal volume and we have the total volume, we get the coronary wall thickness. So now all of a sudden, you're not waiting for a plaque, you're not waiting for a heart attack, you're finding this early on in patients. So what does it look like? This was by far the best proof of concept we could have done. 100 patients in the door, 100 volunteers in the door, First thing we show, there's a 20% increase in just that coronary wall thickness. And you could say, well, is that really plaque? Well, when you adjust for cardiovascular risk factors, there's something about the psoriatic state that increases vascular wall thickness and unhealth of the coronary vasculature. If you take your scientific calculator and you pull that out, and I'm actually going to do it. If you pull out a scientific calculator, you put up calculator on your little phone. I'm an iPhone user, sorry. And then you turn it to the side. You get something here called e to the x. I don't know if you've ever used that, but e, you could bastardize an odds ratio by saying 0.13 and then go e to the x. And what does that give you? It gives you 1.148. So that means 15% increase in in non-calcified coronary burden by the sheer presence of psoriasis. So you can now tell your patients, hey, did you know just by having psoriasis, you have about a 15% increase in this non-calcified burden? They may not know what you're talking about. But then when you talk about it, you say, actually when someone ends up with a heart attack, that non-calcified plaque is actually what's causing the heart attack. So for the first time, we were able to say, wait, Joel and I discovered that heart attacks happen between 40 and 50, and these patients are starting to get this non-calcified burden in their late 30s to early 40s. Then, in their late 40s, they're getting these plaques. And so the next part of that paper in 17 was saying, well, now, what if you have an actual coronary plaque? So before we said the walls thicken, but now when you look at these plaques, do they have high-risk features? Prone to rupture. And there's 3 such features in cardiology known. Positive remodeling, if there were so many people in the room and it was standing room only and it was spilling out the door, that's what positive remodeling is. There's just no more room in the wall, so it just pouches out. Low attenuation, it's full of fat. So when you look here and you see these ratty white spots here, look like little mac and cheese balls, that's low attenuation plaque. And so those 2 really predispose you to having plaque rupture. So we asked the question in that same paper, are these high-risk rupture-prone plaques present in psoriasis? This is a 38-year-old patient, severe psoriasis, owned a deli. If you've heard my talk, you've seen this before because it made the cover of Circ. 38-year-old male, wife and him owned a deli, and he was starting to shed, and his wife was like, you gotta get your psoriasis treated. So he comes in at baseline, we tell him to get treated, he's like, I'm not doing injectables, I'm not gonna change my life, so I'm just gonna keep going. Between baseline and year 1, he had a massive right posterolateral myocardial infarction that had a high-risk plaque. And he did go on treatment subsequently after that because we know that it was his untreated psoriasis that drove this. When you look at these high-risk plaques, what's scary is that if you take a patient with psoriasis and those who are hyperlipidemic and 15 years older, you get the same amount of high-risk plaque. So your patients are developing coronary plaque that they're not feeling, and then all of a sudden at 46, they have their first MI, or 35, or 40. It's countless numbers of anecdotes that are now becoming real data. Now to the fun part. In the last about 10 minutes or so, I love telling this story. So I always still look at all my own primary data. I don't believe in reports. My fellows hate me. I always say, let me see the images, right? You don't want anyone else interpreting your stuff. 13th time someone calls me and says, Dr. Mehta, you did it again. What did you do between last year and this year? We're seeing this reduction in coronary plaque. This was the idea that gave me to actually start a biologic therapy trial, is this data. So it was 13 times that it took to bang me over the head to say, wait, something real is going on here. We're losing these shaggy plaques. Nowhere in the history of cardiology had we ever been able to regress shaggy plaques. So we knew we were onto something. And smart medical student asked the question, does treatment of chronic inflammation modulate coronary disease characteristics? I have 3 stories for you. Each one is a paper, and each one is 1 slide or 2 slides coming up. I'm going to start with going through that NCB, that coronary wall thickness. Then I'm going to go through a little bit of coronary inflammation, taking that VI but taking it into the coronary. And then I'm going to end with some high-risk plaque data, which is the most exciting. All of those studies are in the same 120 group of people, okay? It's 90 people who are about to start new biologic therapy. God, these are hard studies to do. And if you're ever a reviewer on the end of my paper, please understand it's not easy to get someone in before biologics, image them, follow them, and get them in after they're a year out. This is very hard work. And then to find 32 who don't want to go on biologics, Not hard. Not hard at all. Like, there are people out there that are like, I'm not going on biologics, so I'll come into that study. So I have 90 versus 30, purely an epidemiological exercise here. Open label, observational. Please don't call this a randomized trial. I just want you to know that we call this an observational study for a reason. What's cool, though, is that when you look at the 90 versus 30, the only thing that changed after you went on biologic therapy was you dropped inflammation. Great. You saw a reduction in CRP, which I told you wasn't great, but you still saw it after biologic therapy. But you didn't see any change in blood pressure, glucose, lipids, or inflammation, okay? What does that mean? Anything you see on the coronaries is due to the biologics, okay? It's not due to cardiovascular risk factors. Panel A, before therapy. Panel B, after therapy. Panel A has this large lipid-rich necrotic core, fibrofatty burden, which after 1 year of anti-psoriatic therapy with secukinumab, I just happened to show you an IL-17 here, you see that there's a loss of lipid-rich necrotic core, which is incredible. This is what ruptures and kills people. And it calcifies, and it reduces its lipid. So probably what's happening is you're reducing bioavailable inflammation, you're reversing the dyslipidemia sort of inflammatory axis, and you're seeing changes in your coronary. I don't want you to believe me until you see the numbers. So all patients saw a 5%, when you went on biologic therapy, you saw a 5% reduction in coronary disease, whereas those who didn't saw an increase, not statistically significant. You saw a reduction in high-risk plaque. I mean, this totally surprised us, whereas those who didn't actually got worse. So this is the time that I pause and I say, untreated inflammation is a dangerous thing for the coronary arteries. In 1 year, you saw almost a doubling of the size of their lipid-rich necrotic core. Not good. So this is actually, that data on the bottom right actually started a very big trans NIH initiative about figuring out why unopposed inflammation is bad over a year's time. And then finally, I did this for you guys because you would have asked anyway, what if you looked at the type of biologics? So if you went on anti-TNF therapy, you saw a reduction in your non-calcified plaque, just barely significant. I don't think it hit significance. But look at the anti-IL-17 therapy. They reduced by about 15% with a high amount of efficacy over the 1 year period. I want to remind you, this was not randomized. There's a lot of confounding, but it actually shows that these biologics work on the skin and they improve the coronaries. And this was in everybody who saw skin improvement. Story 2, what if you looked at the fat around the vessel? Coronary inflammation. So this is PFI data from our group at Oxford, basically showing that when you start with psoriasis, you have a tremendous amount. This is someone who has no luminal plaque, but a ton of coronary inflammation. And after 1 year of treatment, here in this case with an anti-TNF, you see a reduction in that coronary inflammation. In fact, when you looked at everybody who went on, this is the same group of people, anybody who went on biologic therapy became normal after their vascular inflammation scan. Anybody who went on an anti-TNF became better. Anyone who went on a 23 or a 17. It's those who did not choose to get aggressive psoriatic therapy that actually did not change their coronary parameters. Lastly, we got an NIH Director's Award for this work a couple years ago. This was really an incredible collaboration. Imagine you took a blood vessel and you chopped it out and then you were able to image it in and out of the body. That's what this software allows us to do. So here's a coronary artery with a lipid-rich necrotic core, large area of calcium blooming. And what this is showing you is you can actually get high-resolution imaging with these. And what we do is we take these and we look for these high-risk plaques. And what this shows is this is the best picture that we've been able to really convince people. If you had something cheesy in your coronary artery and you had psoriasis and you went on, in this case, ixekizumab, another 17, and I show these just because they're each illustrative, of different processes. You'll see that that lipid-rich necrotic core near disappeared and the calcium increases. So don't let people tell you calcification is a bad thing in the body. It is, if it predates injury. But if it postdates injury, it's actually a healing process. So how do I end my talks? I really like to be positive and saying, look, in our 400 people over 4 years, now up to 10 years, we have found a high prevalence of adiposity. Fat is the new enemy, and we'll talk about that at the end. A high evidence of dysglycemia and dyslipidemia. but it's modifiable. So when you come into our study, most people lose 5 pounds just talking to our dietitian over about 6 months, small, frequent grazing meals. And our patient, I just want to show you what happened to her in our study. So this is her. 44, family history of diabetes, family history of coronary disease, low risk by Framingham risk score. I don't expect you to know what this is. This is a bad, severe LAD disease, so you'll see it right here. This is a 44-year-old female. She's probably had moderate untreated psoriasis for 8, 10 years, like what we'd heard. And she has this. She has a serial 70 and a 49% stenosis in her LAD. She walked out of her office surprised, happy, right? Happy. She's now 4 years out on treatment, never had to get anything done to that. But what do we do in the meantime? So, happiest professional day of my life, December 18th, 2018. We got into the guidelines. So this is the ACC AHA, my, parenting body of, sort of work. And you'll see that when you have a chronic inflammatory condition, you warrant early statin therapy. So your 20 and 30-year-olds who are looking at you like you are completely ludicrous, say, no, this is actually going to save your life. It's going to save you from blindness, stroke, heart attack. It might even make your psoriasis better. I just want to remind you here, we just received funding from the National Psoriasis Foundation to do something that is, in my opinion, one of the things that we should have been doing a long time ago. We're putting statin prescriptions in the hands of derms and rheums. So we're actually going to be randomizing 90 sites to giving statin prescriptions to patients with psoriasis with the primary goal of saying, can you reduce their LDL, right? Just a simple, we're going to reduce your LDL. So Joel Gelfand and I are rolling that study out later this summer. It made your AAD guidelines. It made the NPF guidelines. It made EULAR guidelines. Watch your patients. And I think I took the last segment out just because I thought I'd run out of time. But what do I recommend you do? Do the 3 Bs. Check their blood pressure, check their body mass index, and check their blood for glucose and cholesterol. So in these guidelines, I wanted to call it the Mehta 3 Bs. It never quite made it in because they're like, we don't have enough evidence on one of the Bs. But maybe we can make that evidence together. Check their body mass index. I should not be the first person telling your patients that they're obese. Check their blood pressure. There's a ton of diastolic hypertension that is shaving their endothelium down every day. And third, check their blood for cholesterol and glucose. I don't care if it's fasting or not. Just get it done. You're going to need to know where they stand. This is cool. I know it doesn't project well, but I just wanted to put in a plug. The Psoriasis Foundation and I developed an infographic, and you can basically get from this that what is the hyperkeratotic, skin disease that is psoriasis is rooted in systemic inflammation. And that systemic inflammation causes beer bellies and metabesity. It causes depression and anxiety. It causes heart disease and stroke. And it causes psoriatic arthritis in 1 in 3 patients. So at the root of all of this are these comorbid diseases. And we got to get better at treating the patient's inflammation before these develop. So in conclusion, it's a systemic inflammatory disease. I really hope you don't, not think it is. It's associated with cardiovascular disease. I'd like to call it a risk factor. I'm not allowed to yet. And treatment of psoriasis is important in reducing systemic inflammation. Notice I don't put vascular disease there yet because we still need our randomized trials. And with that, I will put my email up everywhere I go, and I have my Twitter handle there. I would love for you to follow me on Twitter, watch our work, tell me what we need to do in the field. Honestly, what do we need? It started with, does treatment matter? Well, now we know it does, and I'd be happy to take questions. Thank you.